the left. There are a couple of events to the right here in patients, but by and large, this is a pretty clean looking long-term follow-up. And this is the way things have been in the patients who've been followed out 10, 15, 20 years. They have done very well with no additional strokes. There have been some rare exceptions to that. But I can tell that most of the patients, that post-op arteriogram looks good. You're going to do well over the long term. The girls are going to be married. They're going to, if they want to have children, they're going to have children. They're going to live full lives. They're going to be skiing. They're going to be, I don't have any gymnastics like that, Gary. That was fantastic. That was beyond, that was great. So the long term, again, you know, when I talk to families about what's going to happen, I say to them, look, the surgery does not bring damaged, destroyed brain tissue back to life. It can't do that. We don't have a way of doing that yet. What the surgery is going to do is prevent further deficits from occurring. There's going to be a risk with the surgery, and it depends on the patient. The patients that are sick, that are having lots of events around the time of surgery or just had a stroke, they're at higher risk to have a stroke around the period of the surgical operation. That, and I think that makes sense. But once that surgery is done, the odds that there's going to be a long-term stroke are very low. But if the child has injury to the brain to start with, as I mentioned, the surgery isn't going to bring that back. So it depends what you start with. If a patient has bilateral severe strokes before the diagnosis is made, the prognosis is not going to be as good. If the patient has a dominant hemisphere stroke that affects in a right-handed person the left side of the brain, that patient's prognosis is not going to be as good. And if that patient has an associated problem, like a brain tumor that's been treated with radiation, for example, that patient prognosis may not be as good. There are complicating factors, in other words. And I mentioned we had one, I didn't mention, we've had one death in the hospital due to a child just kept having strokes. We couldn't stop them, but that's luckily been a very rare event. And we've had 4 late deaths. You know, it's interesting that Gary talked about this Seckles dwarfism. That patient that he showed had this variant of dwarfism with an aneurysm, and we've had 2 children like that with aneurysms as well, one of whom died when one of these aneurysms was ruptured. And we've had some deaths that have been unrelated to moya that have occurred as a result of the treatments that the child had for other reasons, for other conditions. So the other interesting thing we've learned is that the early age of onset is not a bad omen necessarily. If you look in the literature, you know, you see a little kid, say 1 or 2, presenting with these symptoms, and they say the prognosis is dire. It's not. If the diagnosis can be made early enough, those kids should do just as well as anybody. So Gary talked about patients with hemorrhage. I mentioned we had 8 children with hemorrhage. I'm going to go very rapidly through this, but just to say that it works pretty well for hemorrhage, and you wouldn't understand why that happens, except that we think that the hemorrhage these patients have comes from those moya vessels, and they're thin-walled and that break and bleed, and the surgery sometimes will induce the gradual disappearance of those moya vessels and lessen the tendency for hemorrhage. So we've had, again, I'm going to go through this very rapidly. In the 8 patients we've had, once they've been operated on, we've had no further hemorrhages, and we've got very long follow-up on them, an average of 10-year follow-up with no additional hemorrhages, which is a very good long-term rate, I think. I'm not going to show this arteriogram, but that was, now, I mentioned this very briefly. Can adult patients be treated successfully with indirect operation? Sometimes you have to do an indirect operation in an adult patient. The arteries are simply not big enough to do a bypass on, and you have to, or there may not be satisfactory recipient vessels, or there may not be a sizable or any scalp vessel available for the surgery. So we've had, as I mentioned, we've had 21 patients who have done this technique. You can see the presentation here, 1 bleed, but most stroke and TIA. The average age of surgery was all over the lot, but my patients tend to be younger, my adult patients. They're in their 20s and 30s. And you can see the associated risk factors. Again, just like we talked about Graves' disease, Gary had a couple patients with this is an autoimmune disease with some sort of a thyroid inflammation that's taking place here, and why this causes moya moya, I have no idea, but other people have talked about it. This is interesting. One patient with cocaine was a cocaine abuser, and I don't know whether you know about the effects of cocaine on the brain, but it causes blood vessels to narrow, and at least transiently, and sometimes can cause brain hemorrhage. This was a chronic cocaine user, and she developed moya moya syndrome from that. So anyway, these patients also have done well. I want to show you this atrophy process of the moya moya vessels that Gary showed a picture of also. This is a who presented with strokes, and I don't know whether you can see all of these black lines on dots in the scan here. All of these black dots in the middle of his scan are these moya moya vessels caught on end as they're going up through the basal ganglia. Now she has the surgery, and then she has her scan 4 years later, and they're all gone. The brain, you would never know that this patient had moya moya because of the induction here of the shriveling of these blood vessels due to good blood flow getting into the brain. These blood vessels are no longer needed. And the arteriograms on these patients, we've all been showing arteriograms today, but this is a post-op arteriogram on this is who's 1 year post-op, and you can see the results here. These blood vessels are filling the whole side of the brain here, and so the results in adults can be very, very strikingly good. And this is a frontal view. All those blood vessels that are out here, all these blood vessels are new coming in from the sedangiosis in this adult patient. And, oh, this is the slide that Gary was waiting for. This is a comparison between the indirect and direct on a patient. This is a 28-year-old woman with Down syndrome. And on one side of her head, she had a blood vessel big enough that we could do a bypass on. And on the other side, it was not big enough. And here's her follow-up, 1 year follow-up arteriograms. And, you know, the results are really about the same on both sides. But Gary's right, the bypass works faster. I mean, you can put that in right away. But the results, the long-term results, I think are about the same. Of course, they're better in this patient on the right. So I'll conclude here by, you know, saying that certainly for docs, you know, I talked to docs about this. I said, look, you all have to pay attention to patients that present with these symptoms. You have to look at the associated factors. You have to think about the children and say, this isn't just something to toss off. You know, you have to think about moya moya as a diagnosis. You have to look at the studies and pay a lot of attention to the MRI. Look for the appearance of we call them the flow voids of these vessels at the base of the brain. And moya moya, they're small, but sometimes people don't look at them. They look for stroke, and you may not see a stroke initially. That's really important. And you have to be aware that the condition may occur if you have a patient who's in that right associated group of patient. If you have a patient, for example, who's Asian in extraction, or if you have a patient who has neurofibromatosis, or a patient with Down syndrome, you've got to think about these conditions. And then I think the other thing that's really important is when these kids undergo anesthesia, they really have to have that anesthesia managed carefully. If I have a patient who's seen who has within a year of surgery for the moya moya, it then has to go undergo anesthesia for another condition, having teeth extracted or some minor surgical procedure. I say, look, you have your anesthesiologist. Talk with our anesthesiologist. Get that protocol down. Make sure the patient is managed carefully, because that's another problem area. Once a year goes by, after, at least in our own experience, there aren't any problems with anesthesia, but that's very important, I think. And I think these indirect operations, certainly in children, work pretty well. And I think there's no question in my mind that, in looking at this group, there's absolutely no question in my mind that when these youngsters undergo surgery, their long-term prognosis is going to be excellent. They should be able to lead normal lives and productive lives. The important thing is, though, the follow-up that Gary, Ed, and I get from you all. We have to keep getting that information, so don't forget your doctor, and keep your doctor informed about how you're doing. And DJ, I can't tell you what a pleasure it's been to come here to Philadelphia. It's my hometown. and to be able to talk to this group. And Gary, Ed, and I know appreciate your invitation to do this. And Shari, thank you. Thanks, everybody.